Well, hello and welcome to another edition of Health Solutions with Shawn and Janet Needham, where Team Needham discusses everything healthcare. I am your host, and I am streaming live from Sioux Falls, South Dakota today, and I am super excited to have Dr. Josh Leavitt back on our program. He was with Nampa Direct Care in Nampa, Idaho, and he'll talk a little bit about direct primary care also, which we've had talked about many times on this show. And we're going to mostly be discussing statins today and cholesterol and how it correlates with cardiovascular disease. Now, one of the big ways where Dr. Leavitt and I really connected, I think he realized that we were on the same page when we're both like, statins, I don't know so much, and cholesterol, I don't know. There's more to it than that. So that's really how I think Dr. Leavitt and I really connected, and we've become good friends since. So, Dr. Leavitt, I appreciate that. And Dr. Leavitt, welcome to our show.
Thank you so much, Shawn. It's good to be here again. I appreciate the opportunity.
Yeah. So last time on our show, we discussed some other things. I think a lot of time we focused a little bit on diabetes and how you've helped people get off diabetic medications. And we were talking a little bit about statins, and we got into some blood pressure issues too. But really what we're talking about a lot of times is, these lifestyle related diseases that you help people get off medications that they're lifestyle related diseases, and you're able to spend time with them in order to get them off medication. Can you explain how direct primary care works and how you're able to get them off medications because of that? Absolutely.
I mean, first of all, it's important to let everyone know that I'm a board certified family doc. I'm an average family doc with an average practice, although it's a little different from usual way of doing it. I'll explain that in a minute. But I do have a license to prescribe. I don't just de-prescribe medications, but I would say that my practice model allows for me to spend a little more time with my patients and potentially get them to follow those lifestyle recommendations prior to starting a medication. But if there does come a need for a medication, I'm not entirely against it. I think it's just a suboptimal way of doing it. For example, I don't just see an elevated hemoglobin A1C or an elevated blood pressure, or definitely not an elevated total cholesterol, and just throw somebody on a medication. There's much more to the story, and everyone's story is a little bit different, but I feel like if we spend a little more time with them, we can get them to change a few lifestyle measures and potentially avoid the medicine in the first place. But don't get the wrong idea. I do prescribe medication. I actually dispense from my own pharmacy here. Have a lot of different blood pressure pills. I even stock a few statins to my dismay.
I get it. So do I.
There may be a select few people who would benefit from that. And, we have to look to our, cardiologist, specialists and the researchers for that. But again, we have to take the research and really study it out and try to figure it out. And I've tried to do that. I don't profess to be a lipidologist or a super expert, but I have a lot of experience with my own patients and spending time with them and trying to figure out, okay, are there too many side effects? Is this more risky for you than it is beneficial? And we'll get to that. But anyway, in general, direct primary care is a form of providing primary care for my patients where I don't bill insurance. I'm not having to see as many people in a day. I get to spend more time with them because they cover my cost or my charges, via cash. They pay a monthly membership fee to be my patient. We take care of a lot of their needs. If there isn't a need for an in-person exam, we do that via text or phone call, especially follow-ups on labs like we're going to be discussing today. So, and then medication changes or addition or whatever might need to happen can be, at the patient's convenience. They're on a break at work. They don't have to take half a day off to come in and see me. So there's a lot of benefits there. But I really enjoy spending more time with my patients. For example, I spend an hour with each patient when I first meet them, and we study out what's going on with their health and try to figure everything out. So anyway, that's a brief summary of direct primary care and how I do it.
Yeah, it's invaluable tool in the healthcare model, and I'm glad it's growing. And I appreciate doctors like yourself that really took a risk and went out on a limb and kind of, went against the grain with the traditional healthcare system. Because I think it's not only, I say it's the future of medicine, but really it's the present of medicine, and it's the past of medicine. It's how doctors used to take care of patients, and it's really cool to see the movement growing. So thank you, Dr. Leavitt, for being part of it.
You're welcome. And I mean, it's important. I did point it out in our diabetes, discussion that I don't feel like I'm better than my counterparts, the people that I did residency with, my other fellow family docs and internists in this area are phenomenal doctors. They're brilliant. I do feel like I have more time to spend with my patients, and I really, really enjoy that. And I really feel like for me, it helps me get to the bottom of their needs. And we make a connection, and then they also trust what I recommend. And I've seen people improve that way, whereas it seemed like a lot of people weren't improving when I was a little more rushed and all that.
Right. And, patients are, let's face it, I know medicine has become so cookie cutter, with standards of care and all those things. But, but at the end of the day, patients are individuals, and they need to be treated as individuals. And, we'll get into that with some detail today with people's cholesterol numbers. But ultimately, labs aren't just black and white. They belong, those lab numbers, lab levels, blood levels, whatever you want to call them, they belong to a patient, and they need to be treated appropriately.
Agreed.
Yeah. So tell us a little bit about what your thoughts are on cholesterol and statins.
Absolutely. So my experience has been that the way that the medical community is treating cholesterol may be a little aggressive with regard to total cholesterol and LDL, low density lipoprotein, the quote unquote bad cholesterol. And I can speak from a personal experience in that when I spent less time with my patients, I jumped to using health calculators or calculators to help me determine whether someone was at cardiovascular risk or excess cardiovascular risk. And they seem to be heavy on total cholesterol and low density lipoprotein. And if the patient had that, plus they had a blood pressure history or a family history, or certainly if they were diabetic or pre-diabetic, then it seemed like these calculators, these generators would recommend me, would say the patient had a 10-year risk that was excessive, and they would recommend a moderate to high dose statin medication. And I found that I was prescribing those things very frequently. And since my reason for even getting involved with trying to change the status quo here was finding that if you talk to the patients, you would find significant side effect profile that may not justify using those calculators and just putting people on the meds whenever, the calculator said, well, their 10-year risk is too high. Let's recommend a medication for that. So really my interest in going back to the research and looking at these studies that were done was saying, does the risk outweigh the benefit? Or the other way around, does the benefit actually outweigh the side effect profile? And I find that especially in primary prevention, I don't think it does. I don't think the benefit outweighs the risks of the terrible side effects that I've seen in most of my patients who are on it. And even the secondary prevention stuff, so someone who's already had a heart attack or has significant vascular disease, I still feel like the improvement or the expectation of lowered mortality and morbidity is low enough that it's still a toss-up whether you should do that or not. I think it's a good idea to get a cardiologist or a super specialist involved so they can help make that decision. But I still spend a lot of time with my patients and teach them, if you're having these side effects, you should, you get to make that decision for yourself, and then actually teach them about the absolute risk reduction versus the relative risk reduction. So I guess that was a little bit of a, kind of like throwing a bunch of information out there, like
right, yeah, right.
What it just reminded me of as well is back when a lot of drug reps would come into the clinics and talk to us about these medications, which has, this sort of occurrence is much fewer and far between now, but it did influence me prescribing statins when Lipitor rep or Pravachol or whatever it is, the Pravastatin rep would come by, and also just on any of the ads that people see on television and stuff like that, the absolute risk reduction is not what's reported, it's the relative. And so the person thinks they're going to have 50 to 100 or 300% less chance of having a heart attack, when in fact that's the relative risk reduction, and the absolute risk reduction is much, much less. So I'll get to that in just a minute. But anyway, when I started looking back into that, also considering how frequently I saw the side effects when I was able to ask my patients how it's going, and when they noticed the fact that they had less core muscle strength or proximal muscle strength, like weakness issues in their shoulders, in their hips, or memory loss issues and things like that. Well, my memory went to crap whenever I, started seeing the doctor and getting put on these medicines, and you start to tease it out. You say, there are some significant side effects to these medications. So let's go back and restudy whether they're actually justified in their risk reduction. So that's kind of what my story is. And then I found that there's evidence. I mean, there's minimal evidence that an elevated LDL or total cholesterol, there's a little bit of evidence that shows that. And then there's enough evidence on triglyceride level as well that it's problematic. And especially if you have both of them, then there is a risk there. But again, what kind of risks are you willing to assume when you start a medication that's even riskier most of the time, in my opinion? So,
well, and a lot of times, I'm going to ask you some questions on specific numbers a little bit later. But what the thing when I use myself as an example. So my cholesterol literally, and I use this, it sounds like an extreme example, but my cholesterol is literally like 201 to 210. So,
okay.
And anything above 200 and you're at risk for cardiovascular disease. And I would almost guarantee you, Dr. Leavitt, if I went to a traditional cardiologist, they would say, well, Mr. Needham, you need a statin. Now, my triglycerides are like 65. My LDL is like 65 or 70, something like that.
Right.
And, I'm not a smoker. I don't have hypertension. I'm not a diabetic. I don't have
You've never had a heart attack before.
Right. So it just doesn't make sense sometimes when they put people on statins just because of that. Or I've got a good friend. He's in about the same kind of health condition I am, but he's 65. And when he turned 65, they said, well, you should probably take a statin. Well, why? Well, because you're 65. What?
No.
Right. And that's what his cardiologist told him. So,
right.
Let's explain some of those numbers that we got into and, and get into the nuts and bolts of it so we can let patients, decide for themselves on what is the risk for cardiovascular markers.
Absolutely. And I think that leads into the discussion of what is the absolute risk reduction. And first of all, with you and your friend, you're talking about primary prevention. You're not talking about secondary prevention. So that's the first group. And so those are people, for those listeners who aren't familiar with those terms, those are the people who don't have cardiovascular disease already. And the question is it worthwhile to start the medication in someone who doesn't already have cardiovascular disease in hopes to prevent it? So primary prevention. And of course, we all know that there are risk factors for cardiovascular disease. And of course, people who have multiple of those risk factors are more likely to go on and get the disease than someone who doesn't have them. It's pretty basic stuff. But what you have to look at is the studies that are done and whether it looks like primary prevention with a statin medication is justified. And so if you look at those numbers, the studies, in my opinion, don't really pan out, even though the researchers do report, in men at least, that the primary prevention with a moderate dose statin helps reduce the occurrence of a heart attack or death by, an endpoint of death by heart attack or whatever, enough that they say it's statistically significant. Well, it turns out that if you look at the absolute risk reduction, it's only about between 1% and 2% absolute risk reduction for men. And if you look at it for women, it's only about between 0.5 and 1 percentage point. And that's actually not statistically significant, whereas for the men it was. But if you think about it, or if you let your patient decide, they're going to say, there's no way I'm going to assume this side effect profile for this medication for that small of a reduction. And yes, I understand that with statistics, we're talking about, millions of people, not just a select few people where 1% doesn't mean a thing. But even in my opinion, I think that when you're talking a absolute risk reduction of 1%, even if it does, the p-value shows that it's statistically significant, I think you got to take that with a grain of salt. Also, where the study had come from and all that kind of stuff. So
yeah. Now, can you, for my simple mind, can you explain in detail, give us an example of absolute versus relative risk let's just base it on 100 patients, because that will be an easy number to compare. So compare a 50% a relative risk reduction versus absolute on 100 patients. Can you explain?
Yeah. And I think using the 100 patients for the men in this category would be if you studied 200 men, 100 on statin, 100 without it, or on a placebo medication, then you would expect over a year's time that in the statin treated group, one person would have a heart attack. In the non-statin treated, so the placebo group, 2 people might have a heart attack.
Right.
Okay. That's 1 percentage point different, but it's a 50% reduction in relative risk.
2 versus 1.
Versus 1%. Yeah. Right. And the reality there is probably that it's less than 1% when you calculate it. I don't know all the specifics. Yeah. And I have, this is stuff I looked into a long time ago, but I have looked on my sources to make sure there aren't studies that just came out last year or in 2018 or 2019 or something, just to make sure I did my due diligence, that there wasn't some breakthrough study that, oh my gosh, statins are just incredible now, right? So I couldn't find it, but if any one of your viewers does find that, if they could let you know and you could immediately text me about it, that'd be fantastic. Because I don't know everything, people, but I do know that in my experience, the bad that comes from these medications is worse than the good that, or it is worse than the bad that comes from not taking them. That's my opinion, because I've seen so many people with bad side effects that go unrecognized because these are basically felt like we should just put it in our water and every human being should be on a statin when they're above 65, like you said. I don't subscribe to that belief system, and I don't think it's backed by science either. So, but if any of you disagrees and feels like the science shows it, I'm happy to hear it. That's no problem at all. So anyway, but so that was the absolute risk reduction versus what you would hear. Okay, it's a 50%, and then in certain categories like with secondary prevention, it's that or a little bit more, 75% or something like that. But yeah, I think that gets skewed, and we have to educate our patients that what they hear on TV or from whomever, could be misinterpreted or at least being misrepresented to make them feel more like they need to be on this medication. And then go ahead.
Well, I just want to elaborate, just to explain for my simple brain mostly, but on that example on relative versus absolute risk. So the absolute risk was 1% of a heart attack, because 1 person in 100 had a heart attack. But when they compare the treatment group, where 1% had a heart attack, the non-treatment group or placebo group, 2 people had a heart attack. So the 2 versus 1 number, that's where they get a 50% reduction risk. When in reality, it prevented 1 heart attack out of 100. Correct? Am I correct on explaining that?
Well, I'd have to go back to the numbers and make sure that we're just not oversimplifying that.
Right,
But, you know,
right.
yeah.
I
think it's a good representation of how they get from,
correct,
50% to true 1%, right?
Yeah. And that's kind of what I wanted to explain is relative risk versus absolute risk. And there's a lot of drugs that are studied that way. And it's a little bit deceptive when they say how effective they are when they do relative risk versus absolute risk.
Yeah. And I guess we can jump into, there are, the studies, and they say they're statistically significant. There are some studies where even, those of us who'd rather our patient not have to take the medication, there are times where we do cave in and say, or cave to it and say, okay, well, they have significant risk. If the cardiologist recommends that, then I'll go with it. Okay. And that's because in the secondary prevention studies, they did see for males in between the 4 and 6% reduction, and in females in between the 2.5% to 5%, something like that. Don't quote me exactly. Go back and look at the study. But it's similar to that where, it was much different from primary and still barely a percentage point. But I think we should report it to our patients because they should be the one who gets to decide.
Right.
Now, a lot of them in this age category especially will just go with whatever the doctor says, But I like to discuss, this is how you feel on the med. And if you're lucky enough, you don't appear to have any side effects, fantastic. And, your cardiologist or whomever is recommending the med, fine. But still keep an eye out for those side effects because they're not benign medications, especially with what I've seen people have to deal with. So anyway, that's why I started looking back into it, because everybody was sicker on these things. I was not happy about it. And I try to de-prescribe them wherever I can.
Well, one of the side effects we didn't talk about, I don't think you mentioned it, but you mentioned muscle pain, which is a big one, but we didn't talk about liver side effects, but they can be very toxic to the liver. Correct?
Right. Yeah. That's where they're primarily processed, and it right. does a number on it. And so one of the tests that we have to run, of course, after we've started somebody on it, is their chemistry panel and whether or not their liver is tolerating the med. Preferably done, 2 to 4 weeks after they start it, not the day after, because it might not be affecting it quite that much, and certainly not months and months later, because what if it's really messing it up and you let them, potentially get some scarring and stuff like that. So anyway, they're processed by the liver, and it can be, liver toxic. So
tell us a little bit about, let's break down, cholesterol has been vilified so much, but let's break down, a lipid panel and what you see and what the studies say is more important than just total cholesterol. Let's just go ahead and go through some of those numbers.
Absolutely. So it has a total cholesterol. It has the HDL, which is, commonly known as the good cholesterol. It has the LDL, which is commonly known as the bad cholesterol. Those are actually, some of those values are directly calculated or directly observed, and then some have to be calculated. I actually don't profess to know all the little ins and outs there. I just look at the panels, and I've seen so many thousands of them over my career that I feel comfortable interpreting those data. The panel also has triglycerides, and then it'll compare the total cholesterol to the LDL. It'll compare it to the HDL. It can compare the triglycerides to the HDL, which is what I like to do. One of the reasons why I've done that is when we're worried about somebody having too high of cholesterol, we're usually correlating that with other metabolic disease like diabetes, hypertension, that sort of thing. And so what I've done is correlate all the labs that I've done with my patients and keep kind of a running feel in my brain of what's problematic and what's not problematic. Okay. And if anyone's seen that video of us when we did the diabetes talk, you'll know that I'm big on trying to figure out whether somebody has that evidence of that early metabolic disease that I call insulin resistance. And what we see there is the correlation of early prediabetes or just full-blown prediabetes or diabetes correlating with an elevated triglyceride level. It's usually because triglycerides are high when somebody's fueling their body with a bunch of processed food, right? Sugars, grains, that sort of thing. And the triglycerides will be super high and their HDL is usually pretty low. And if you correlate those two together, it correlates with abdominal obesity, it correlates with prediabetes and diabetes, and just mishealths in general that we as primary care people see when people come through our doors. So anyway, I hope that helps. Did I answer your question?
Yeah, you sure did. And now triglycerides, that's kind of like the amount of, for lack of a better term, that's kind of like the amount of fat that's floating around in your blood. Is that correct?
Right, it is. And it directly correlates, interestingly, not with the amount of fat that the person eats in their diet, whether that's, plant fat from avocados or coconut oil, or animal fat from, the fat on bacon or a steak or something like that. The elevated triglyceride level seems to correlate directly with the carbohydrates in the nutrition and whether or not the patient can tolerate their amount of their carbs that they're eating, the sugars that they're eating. Because my diabetics, whose bodies are really having a serious problem with sugar metabolism, have triglycerides through the roof. And my people who are eating more of a whole food nutrition plan, mostly meat, eggs, cheese, and vegetables, without a lot of even natural sugars, but certainly not a lot of processed sugars and grains, tend to have better numbers that way. And they also tend to feel better and have less inflammation and all this kind of stuff. So,
right. So tell me how, when we talk about cardiovascular risk, cholesterol or lipid panel for that matter is just one part of the whole story of cardiovascular disease. Smoking, I mentioned that is one of them, and hypertension is one of them, high blood pressure, and diabetes. So if you were to look at a patient as an individual and they had diabetes and they were a smoker and they had high blood pressure and they had high cholesterol, what is the first thing that you would address with them?
You said they are a smoker?
Yes.
So I would address two things that visit, and I would help remind them that smoking is a very problematic thing for their vascular health, and I would teach them why. Nicotine being a very inflammatory substance and directly toxic, directly inflammatory. And then also explaining, depending on their body habitus, you might approach it from an overweight or obesity standpoint. But even if not, some smokers are very unhealthy vascular wise and are very rail thin because of the chronic effects of nicotine as well. So it's not a great argument to someone who's, thin. Oh, you need to change your diet. They're like, no, I don't. I'm not fat,
Right.
So, but also explaining the fact that a poor nutrition plan can lead to vascular damage as well through inflammation or through elevated triglycerides, that sort of thing. And what I would approach is a better nutrition plan to lower the inflammation, to lower the triglycerides, optimize the lipid, profile, which in my opinion has a lot less to do with total cholesterol and LDL than it does to optimizing HDL and lowering triglycerides, because those two, that ratio of triglyceride to HDL, being less than 3 or certainly less than 2 optimally, but less than 3 ideally, or whatever. I less than 3, okay, less than 2, better, like ideal, right? Sorry about that. And then, so I would discuss those things and show them, or actually inquire of them. What I would do is ask them to start making a log of, what they're eating and then how much they're smoking and that sort of thing. And we can do some labs and show them that the inflammatory markers are better, that their lipid profile is better and that sort of thing when they're, and they can correlate it with what they say they've been doing in their, in the log that they keep for me. So that's what I would do. And I would allow 3 to 6 months of those changes to happen before I would just throw a medicine at somebody. That's the ideal thing, which I don't think happens enough, especially when we don't get to spend enough time with our patients, right?
I agree. Well, I talked to a doctor one time, and he mentioned to me about he was comparing statins. If you had a patient that came in, they had cardiovascular risk and they were a smoker and they had high cholesterol, he mentioned a study that he quoted that to prevent heart attacks, you're better off prescribing a statin than telling them to stop smoking. Now, I'd like to see that study. Maybe there is some kind of correlation. My doubts are probably, my gut feeling is no. But here's one of the ways, what I was thinking about the situation is that, smoking has more problems than just cardiovascular risk. I mean, so let's treat the patient as a whole. It's like, if they stop smoking, they will feel better within a week. I can almost guarantee them. I mean, they might have some withdrawal symptoms, but they're going to be better, breathing better. They're going to be feeling, having more exercise capacity. So, that's why we need to not treat patients as studies or quote studies and just say, hey, look, smoking's bad for you. And this is all the problem with smoking. It's not just about having a heart attack. If it's for your overall health, you'll stop smoking, and then address the other problems later, whether it be the diabetes or the high cholesterol, address those later, because smoking is probably, darn near one of the worst things we know, as healthcare professionals. It's probably one of the worst things you can do to yourself.
Right. Agreed. This is completely off the statin topic, but one of my side jobs as a family doctor is a hospice director, and I've been doing that for more than 8 years. And you see the ill effects of those poor decisions. Mm-hmm. And we're talking people dying in their 50s and early 60s with chronic tobacco use, right? Specifically chronic cigarette smoking use. And, you don't see that even in type 2 diabetics who don't really, manage their insulin or their glycemic levels at all. You still don't see them pass until their 70s, 80s on average. Whereas the smokers are 20 years earlier. That is a bit, and I'm talking years of seeing, more than probably 100 people die per year with COPD. And maybe I'm exaggerating. I don't know. I don't ever do the math, right? I think that's kind of bad to tally up your hospice death numbers, right? But, I see people dying so much younger in that population that I definitely would bring up the smoking first, but I would feel like I'm not doing a good job if I just put somebody on a statin and hope that worked better than giving them good nutrition recommendations, which is to eliminate those processed foods that drive the triglycerides through the roof and drive the insulin through the roof. And then eventually the glycemic control goes crazy. They can't control it. They become diabetic. And then we know that it's all downhill from there most of the time. Although it's not a lost cause. We went over that last video, but anyway.
It's never too late. There's a story that I had a family member, in-law actually, and he was in his, I think, 80s, and just the gamut of medications, and he was in a nursing home, high blood pressure medications, cholesterol medications, diabetes medications too. He finally woke up one day. He said, "I'm done." And Dr. Leavitt, he flushed his medications. He refused them all at the nursing home. He said, "I'm done." And he started changing his diet and lifestyle. Within weeks, it might have been months, I don't remember the timeline, he was off his medications. He wasn't, his numbers didn't show that he was a diabetic anymore. And he realized how many side effects those medications were giving him and just making him not feel well. And, and he was, like I said, he was in a nursing home in his 80s. And, it's never too late to change your lifestyle.
Agreed. And that brings up a couple points of what you and I, the reason why we decided to do this kind of de-prescribing sort of discussion on your podcast or on your video cast, is that we don't talk enough about those side effects. I've had 2 or 3 people just in the last month or so who've been put on antihypertensive medications, one of them on a statin who's 38-year-old diabetic patient, which of course, most of us who are prescribing know that the gold standard in a type 2 diabetic is to get them on a statin medication as soon as you can. I actually don't subscribe to that mindset. But even so, if they come to us and all of a sudden they're 38 or 45 years old and they're on these medications and we turn a blind eye to the side effects, we're not doing a good job. That's the bottom line. We're not. And the thing is we start to blame these side effects on they're getting old. I'm sorry, but a 38-year-old and a 45-year-old we don't have the justification saying, oh, you're probably just getting old. You get out of bed and it's painful. It's hard to stand up. No, it shouldn't be that way in those young people. And I don't think it should be that way in a 70-year-old either. And I think too many times we are blaming old age on this side effect profile of all these medications. And your friend, in the nursing home is a prime example of that. You stop them, you start nourishing your body with what it really is craving, not just sugar, not any sugar, actually. You can get away from those cravings and do the real, especially high protein stuff in an 80-year-old, you're going to see some results and you're going to be able to stop those meds and they're going to start feeling like $1 million, right?
Yeah. And, what should be standard of care in a 38-year-old with diabetic? Instead of seeing how fast we can get them on a statin, it should be see how fast we can reverse their diabetes. That's what standard of care should be. You're 38. You've got a good 40 plus years of your life left. You do not want to live on medications the rest of your life. I mean, holy smokes about that. And I mean, it really hit home when you said that to me, and I've been practicing pharmacy for over 25 years now. And, 38 is young. And, we're seeing type 2 diabetics that are 38. Of course, there's people with type 2 diabetes in their 20s now. And it's just, it used to be, remember, it was like 65, 70 years old, their pancreas would finally give out, or their not the pancreas would give out, but they would just not become as insulin sensitive. Yeah. And it's like, now we're seeing it in their 30s. And so we're going to put them on medications for 40 years, and that's standard of care. I just don't think that's very quality care.
Right. I agree. And when a patient sees me, and even if I'm the one seeing them after they've been diagnosed and all the meds have been put there, I want to go back and take a step back and say, look, I know that your provider said you have diabetes. Oh my gosh, your A1C is 12. So that means we got to start insulin from the get-go. Or if they were lucky and they got someone to say, look, don't eat any sugar. I don't care what else you do. Just don't eat any sugar.
Right.
Stop drinking the soda, doing whatever they do, the fruit juices and all that. Their A1C went from 12 down to 8.5. Okay, good. Now we don't have to start insulin at least then they're not doing them more harm than good, right? Potentially. And then they might get them on a couple different pills or something. And, as we discussed last time, as long as those things do increase insulin sensitivity instead of insulin production, you're actually making some progress there instead of just making things worse. But you start injecting insulin from the beginning in a pancreas that still works, you're just putting more fuel on the fire. There's going to be more inflammation. There's just as much of a risk, in my opinion, as for a heart disease and stuff because of the inflammation that's just not going away. Yeah, and they keep eating. They'll use the insulin as a crutch to keep eating a very high carbohydrate diet, and their body just doesn't tolerate carbs very well. So you're still creating that risk. Your triglycerides are still high. The inflammatory markers are still high. There really isn't a whole heck of a lot that you've done that's helpful. So anyway.
And more that's hurtful. I mean, really, because more insulin is anabolic, which means it's just going to make them gain weight. I mean,
yep.
We are taught that all the time. And that's the last thing those people need is to gain weight usually.
Yep. Absolutely.
So a quick story on, I shared it with my brother yesterday. I saw this video on TikTok. And for those of you that aren't on TikTok, it can be very addictive, but it's very educational. I will tell you, I follow a lot of health and wellness people on TikTok. We have a TikTok account now. So go to my TikTok account, Shawn Needham, and I put short videos from podcasts like this on those that TikTok account. And I almost, it was unbelievable, Dr. Leavitt. In fact, I don't know if you're on TikTok, but I should share the video with you.
I am to monitor my 13-year-old's behavior.
Right.
I mean, I agree. It can be pretty habit forming there. So be careful there.
Right. Because the videos are so short, you're always like, oh, just one more, just one more, just one more. Kind of like, eating a potato chip. Oh, just one more, Anyway, I almost didn't believe it, but I do believe it because I know that, there are people that are healthy into their 80s and 90s. This 90-year-old guy, he deadlifted 405 for either 3 or 5 reps.
Wow.
And, it's just a reminder that age is just a number. I mean, it really is. And
did you ask him if he started his statin the next day? Or
yeah. Well, that's what I was thinking about. It's like, you think that guy's taking medication? Probably not.
And do you think his LDL is quote unquote normal? Probably not.
Right. I mean, and if, I had a doctor on my podcast a few weeks ago, and this is what he said about statins. And this really, I think clears up a lot of information on statins. And as a healthcare professional, you have to ask yourself just this question. How many times has a patient ever come to us and said, thank you for prescribing that statin? Never. I'm waiting for somebody to say they did. But how many times has a patient came to you, Dr. Leavitt, and said, and I don't know, I'm putting you on the spot, and said, thank you for taking that statin away from me. Now, I imagine they changed their lifestyle, and that's what they thanked you for. But, did they thank you for taking their statins away and changing their lifestyle?
Yeah, I've had that many times, yes. Just right. Because, well, the thank you is more like, thank you for noticing. Thank you for finally asking that question instead of just chalking it up to my quote unquote old age, right? Because I do have to say the majority of people that I'm de-prescribing these medications in are people who would be primarily preventing, right? And who are over 55, probably over 65, right? So they're going to notice the most because they would have been told, you're just getting old. You're 63, and your muscles are going to hurt because you're old, And so they're going to chalk it up to that. But the moment you start saying, wait a minute, when did this start? Does it correlate at all with when you started that medication? And as a reminder, it may be the first time you people hear it, but I doubt it. Cholesterol is part of all of our cellular membranes. Yep. If our cells have to regenerate, if you tear a muscle, you have to produce muscle cells to replenish that, to repair it. If you don't have cholesterol, if you don't have a fair amount of cholesterol in your system, where are you going to get the building blocks to do that? Okay. So if you make your healing suboptimal by taking a medicine that does alter the cholesterol metabolism, it appears to me, based on side effect profile, that it really messes it up. So the moment you start asking the patient, are you having a hard time with that? Does that make you sore? Do your nerves seem to be, getting some numbness? They're not working very well. Is your memory going? That sort of thing. They'll be like, actually, yeah. And it does correlate with right when I started that medicine. And so then you de-prescribe it, and they usually experience a significant difference within that first month. And they'll come thank you for paying attention, not necessarily directly, okay, I'm thanking you for stopping my statin. They'll say that, but it's more like, thanks for listening and figuring out that it was the statin causing that, right? Right. And they don't fault the people who prescribed it in the first place, because it's just trying to prevent a heart attack, right? And that's fine to desire that. The problem is they don't work very well. And even in secondary prevention, they still don't work very well. So you have to weigh out whether the risk is too much for the benefit that you would get. And that's where I feel, especially with primary prevention. So,
yeah, I was watching and you may or may not know this, because I don't keep up with new drugs, especially new statins very, very much. But I was in a restaurant or something, and there was a TV commercial that came on. There's a new statin out there. And I would just be interesting to know, what are they saying? What makes this one better? Why is this one better? And if I did some research, I'm sure they'd say why it's better than, Lipitor, or better than Pravachol, or whatever, or Crestor. Mm-hmm. In reality, that's just a minor part of it is, total cholesterol and how statins work to prevent heart attacks. It's just, there's a lot more to the story.
Right. Yeah. And I think that, Do I think we have perfect studies right now that tell us? No, I think there's probably further work that could be done. And especially I would like to see longer studies that don't just jump to and say, well, because statins are the standard of care, they're the gold standard or whatever, we can't recommend people do 6 months of their own good primary prevention, right? We don't want to take that risk of a newly diagnosed diabetic taking the first 6 months to see if they actually do reduce all of those other factors by eliminating the carbs from their life, right? They won't take that risk because there's already enough information that says that statins are the gold standard. And, and mostly that is through that, presentation of the relative risk reduction sounding so awesome, in which it's not very good in primary prevention.
Right.
So
right.
Anyway.
Well, Dr. Leavitt, I always appreciate your knowledge, and always great to chat with you. And I'll be seeing you in a couple of weeks in person. Just excited for that.
It'll be fun.
Yeah, and just tell everybody, tell us, our listeners and viewers, how people can get a hold of you.
So I have my private practice here in Nampa, Idaho, and I mean, for those of you who are local here. Or in Oregon, I'm licensed in Oregon as well. You can look me up. You can become a patient if you want by enrolling on my website. For those of you who may want to have an educational discussion or share something with me that was different in your mind than what I presented here, I'm willing to hear that. You can reach out to me. My phone number, 208-252-9404, is here at the clinic. It'll get my general manager, who will get me in touch with you that same day. My personal email is leavitt.josh@gmail. You can do that. I'm not great at email. I don't love to do it. It's just more work than anything. So I would call the office if I were you and get on my task list for the day, and I'll get back to you that same day. So that's pretty fast. Otherwise, I think that's about it.
Yeah. Well, I appreciate you being on. Thank you, everybody, for listening and tuning in. You've been listening to Health Solutions with Shawn and Janet Needham. Thank you.